Hello, fellow brain cells. Welcome to the second episode of This Week in Neuroscience. Today we are going to be diving into a particular paper called Psilocybin. I'll learn how to pronounce this one day. Psilocybin therapy for mood dysfunction in Parkinson's disease, which is an open label pilot trial. We'll get into what this is in a second. I'm as usual, I'm putting up the notes here if you want to um be mm, if you want something of a template to be guided by. And we're gonna start right away with the introduction. So as we all know, Parkinson's disease is an increasingly prevalent neurodegenerative disorder and a growing cause of disability worldwide, sadly. Depression and anxiety are some of the most prevalent non-motor symptoms and are associated with poor quality of life. Of course, uh, as even without having Parkinson's disease, these two conditions are debilitating to have, even more with the neurodegenerative disease in the mix. And so the number of clinical trials investigating novel interventions is strikingly, in their opinion, low. Which, if that's true, good job, good call for them, good job. Uh, so once ingested, this should be noted. Once ingested, psilocybin is converted to its active metabolite psilocin, an agonist at multiple cortical serotonin receptors, including 5-HT2AR. Now, what the hell does this mean? It means that psilocybin on its own is not active. It does not react with anything in the body until it reaches until in the metabolic pathways it reaches this condition of being psilocin. An agonist basically means that uh, the particular compound reacts and is recognized by the receptors of another uh, natural synthesized by our body compound. And in this case, psilocin is agonist at multiple cortical serotonin receptors, including this is 5-HT2A, and R, from what I've read, is an additional letter from it being a cortical receptor. Okay, so let's see. Well, what past studies have reported? Past studies have reported that a single psilocybin administration paired with psychotherapeutic support can yield robust improvements in mood that persist long after the drug is metabolized. Which, amazing, quite amazing. Although the mechanisms underlying these sustained effects are not well understood, this is a very common theme throughout this paper. They underline how the exact mechanisms that are at work are very poorly understood and need further research. As always, we need more research, people. More research. And a leading hypothesis characterizes psilocybin as a psychoplastogen, meaning a compound that catalyzes a burst of neuronal growth that can lead to enduring changes in dendritic architecture and synaptic restructuring. Uh, and preclinical evidence, preclinical meaning in vitro with cells or with animals, studies with cell cultures or animals. That's what preclinical trials mean. So preclinical evidence in this case suggests that in addition to agonism at this receptor, modulation of glutamatergic signaling, glutamate is the main excitatory neurotransmitter in the brain. Pathway is critical for regulating neuroinflammation, including the mammalian target of rapamycin, known as mTOR, and tropomyosin receptor kinase B, or TRKB. Now, this mTOR receptor is important for uh, for metabolism and for cell growth. It regulates cell growth. And this TRKB receptor is the main receptor for the BDNF, or brain-derived neurotrophic factor, which modulates neuroplasticity and especially recovery after injury. So these are implicated in the neuroplasticity promoting properties of serotonergic psychedelics. So, while the toxicity of psilocybin is relatively low, its safety for people with Parkinson's disease warrants careful evaluation. Of course, this with all experimental treatments, its safety always comes first. What should we be careful for here? We should be careful that first the drug's vasoactive effects lead to increases in heart rate and blood pressure, which could confer elevated risk given the older age of the individuals and autonomic dysfunction associated that's normally associated with Parkinson's disease. And it is unclear how psilocybin's modulation of serotonin signaling could impact other symptoms of PD. Is altered as altered serotonergic system functioning is implicated or influences both in motor impairment and in psychosis associated with Parkinson's disease. Well, uh, over over 40% of those with the illness develop psychosis, and because of the mechanism, because of the mechanisms at play with psilocybin, there is some concern that psilocybin could precipitate or worsen psychosis in people with underlying susceptibility. And furthermore, psilocybin interacts with other serotonin receptors linked to tremor, uh, 5-HT1AR, serotonin transporter, and dyskinesia, I think that's the way it's pronounced, which is basically, again, involuntary movement, um, involving different body parts. There are multiple types of dyskinesia. Feel free to uh, look it up if you're interested. Okay, so their findings, the previous findings, make it challenging to predict potential effects on motor function from everything that we've said now. And lastly, drug-drug interactions between psilocybin and levodopa, which is the most commonly used and effective treatment for motor symptoms of PD, are unknown. And with these considerations in mind, the authors now have conducted an open-label pilot trial, which is basically open label means that both the experimenters and the patients know that they're being given treatment, and that the experimenters that they're giving treatment, it's not blind, it's not double blind, none of that, it's all open label. And pilot trial essentially being like a test with fewer people, only to sort of as a first test to see whether something has the potential of having a significant effect at all, and therefore, if the results of a pilot trial are good, then the experimenters can proceed with a randomized control trial with way more participants, which is a lot more costly than these pilot trials, and therefore it's better to just have a like a little test of, of whether this has a potential to work or not. That's what it basically is, a pilot trial. So they're using a dose escalation approach to examine the safety, which is normal. They gradually increase the dose, starting from a really small one to see whether it is at all safe. Tolerability and preliminary efficacy, although if it's effective, of psilocybin therapy for mood dysfunction among people with Parkinson's disease. So this was a single-arm, non-randomized trial. As I said, they enrolled people ages 40 to 75 with mild to moderate PD. Wow, Parkinson's disease at 40? That's that's awful. I didn't know. I genuinely didn't know it started um to appear that early in life. That's awful. That's awful, awful. Okay, so let's see the exclusion criteria. Key exclusion criteria included significant cardiovascular disease, cognitive impairment, which is assessed using the Montiel Cognitive Assessment telephone version with a score lower than 18. A lower score means more further cognitive impairment, and telephone version means that it's basically adapted to be taken online, the possibility of being taken online, and lower score than 18 suggests mild to severe cognitive impairment. And use of concomitant medications, which are basically medications that you take at the same time as the medication that you take that's being studied. That could pose a safety risk or interfere with psilocybin effects, including serotonin reuptake inhibitors, so SSRIs, the main antidepressants, monoamine oxidase inhibitors. Monoamine oxidase inhibitors are also considered antidepressants, but they have a different mechanism. They work differently. They basically work with by blocking this monoamine oxidase, which is an enzyme which um, di- mm, breaks down serotonin, so it prevents it prevents the breakdown of serotonin as to more there being more, and therefore the person being in a better mood. Mm. Dopamine agonists, we already mentioned what agonist is, and anticholinergics, which acetylcholine, yes, is a neurotransmitter that is very important for the transmission of signals in the body, so it helps with motor symptoms of Parkinson's disease. And history of mania is also included, which I wonder why, to be completely honest. Maybe because of the dopamine and serotonin. Why do you think that is at all? What do you think? I'm interested. And also, just a second. Oh my goodness. Okay, so primary psychotic disorder as well eliminates you from the study, um, which is understandable completely, or current psychosis involving loss of insight, which means basically you experience psychosis and you're not aware that you experience it when uh, during during an episode. So the sample size is 12, which is quite weak, but again, quite low. But again, this is a pilot trial, so it's totally understandable. And let's see. This is from Nature, yes, I forgot to mention. So this study used pharmaceutical grade synthetic psilocybin, and after screening and baseline assessments, each participant was served with a licensed therapist with whom they had multiple meetings. Each participant met with their therapist 3 times prior to the first psilocybin session, had another 2 meetings between the first and the second psilocybin sessions, and then 3 meetings following the second psilocybin session. So there were in total uh, two um, two psilocybin sessions. So they took the medication two times, of course, with the time interval between them. We'll see later the exact way they did it, the exact design of the study. And each participant first received a 10 milligram oral safety dose of psilocybin, and if this was well tolerated, they were eligible for a 25 milligram treatment dose approximately 2 weeks later. So just 2 weeks later. And following assessment of vital signs and a urine drug screen, of course, any drug-drug interactions could even kill a person. The participant ingested the psilocybin capsule in a quiet room with their therapist present, which is very good protocol. Uh, I'm talking like I'm some expert here. It just to me sounds very well controlled. All of this. Um, I'm no expert on safety precautions in clinical trials. Don't quote me on that. And the therapists provided safety monitoring and psychological support throughout the period of acute drug effects, reporting to an on-site study physician at regular intervals, which they also had a physician on site and ready, which is also very good. Vital signs were assessed at baseline at 30, 60, 90, 120, 240, 60, and 40, 20 minutes following psilocybin administration, which is up to first to like 7 hours. And their primary objective was to evaluate the safety and tolerability of psilocybin therapy, and they assessed vital signs, as we already said, and subjective experience via the five-dimensional altered states of consciousness rating scale, which I I read about. I read about these 5 dimensions, but now I am so not sure exactly what they were, and I'm going to see a bit. Okay, let me just see what the 5 dimensions were, because it's very interesting in my opinion. 5 dimensions. Come on. Oh, there we go. Okay. First was oceanic boundlessness, which measures derealization and depersonalization associated with positive emotional states ranging from heightened mood to euphoric exaltation, which, now that I think about it, is probably the reason they they excluded people with a history of mania. The corresponding lower order scales include experience of unity, spiritual experience, blissful state, and insightfulness. Another dimension, which is anxious ego dissolution, summarizes ego disintegration, which is very subjectively painful. I've been told uh, that you suffer a lot through this kind of thing, and loss of self-control, phenomenon associated with anxiety. The corresponding lower order scales include disembodiment, impaired control, cognition, and anxiety. Another dimension is visionary restructuralization, which is a fancy way of saying they were seeing things that weren't there, and they were seeing the things that were there not as they were in reality. Consists of the lower order scales, complex imagery, elementary imagery, audiovisual synesthesia, hell, even synesthesia, and changed meaning of percepts. Two additional dimensions described auditory alterations and the reduction of vigilance. Which is, oh wow, this is actually a lot of items now that I 15, 15, 12, 18, 21, 27 even, but just means the test is more thorough in my opinion. So yeah, reduction of vigilance, which is the relaxed state that people would who have taken psychedelics are usually characterized with and stereotyped. This is all inclusive of the stereotype, which is interesting in my opinion. And methods, whoops, skip there. Okay, let's continue. So, 1 week after the 10 milligrams psilocybin session, which is these, it's, please remember those because they refer to them throughout the study a lot. So A7, but they have a logic to them, so they're not that hard to remember. A7 is the moment of 1 week after the 10 milligrams psilocybin session, which is the first session, and 1 week after the 25 milligram session, which is B7, and 1 month after the 25 milligram session, which is B30. So specifically, they monitored for changes in Parkinson's symptoms using the Movement Disorder Society Unified Parkinson's Disease Rating Scale, which is a mouthful, but it's apparently a comprehensive tool designed to detect changes associated with disease progression or treatment response that consists of 4 sections. They're evaluated separately. There are 4 parts, and we'll see later the results for patients of each parts throughout this clinical trial. And so, which parts 1 are include clinician and patient reports. Part 2 is completely patient report, and part 3 is a clinician motor examination. Part 4 is a clinician and patient report of motor complications associated with the treatment. So they also measured suicidality and psychotic symptoms, which were monitored by using the Columbia Suicide Severity Rating Scale. So they used like very, how do I say, very, oh my god, very up to date and established. That's the word I'm looking for. Established. They use very well established measures and questionnaires. They do it very well. Um, okay, so as Parkinson's disease is associated with impaired cognitive flexibility, which sounds fancy, but it means literally that your ability to adapt to to stimuli, learn from experience, and everything like that. They administered a probabilistic reversal learning task, or RPL as they PRL as they referred to it a lot of times throughout the study, to assess for changes in this domain. The PRL task is essentially you get mm, a couple of stimuli, and you assign uh, a reward to some of them and a punishment to some of them, and when the person has already uh, been mm, become used to what is a reward and what constitutes reward and what constitutes punishment, they flip around, and it's the exact reverse. The reverse things that usually were associated with the reward now are associated with punishment and or lack of reward and so on. You get that idea. They also took into account care partners observations of the participants, and these observations were captured by the Neuropsychiatric Inventory Questionnaire, or NPIQ, and to evaluate preliminary efficacy for the mood dysfunction, which is the main, of course, the bread and butter of this study. They used the Montgomery-Åsberg Depression Rating Scale and the Hamilton Anxiety Scale. And in addition to the key time points, which we already got through, the Montgomery-Åsberg Depression Rating Scale and the Hamilton Anxiety Scale, along with the Neuropsychiatric Inventory Questionnaire, were also administered 3 months after the 25 milligram session, which is referred to as the B90. So, going on some of the more complex stuff, in my opinion, the data analysis. So, to evaluate changes in these clinical assessments, which is the main thing we're looking for, they used mixed effects linear models, and what this means is basically what they pointed out. Mixed effects is because they both include fixed effects of the times of which they administered the medication, and they include random effects, which are caused by individual variability, because again, every brain is different. So yeah, they put scores as the dependent variables, which they are. The time points as fixed effects. As I said, these are the effects that they control, that they expect to happen, and participants as random effects, accounting for essentially other confounding variables. and they used the R. Apparently, R is still used. If you're interested, they used the LME4 and IMER test packages. If you're interested in pursuing this kind of thing, and they checked normality of residuals from QQ plots, which essentially residuals means because this is a model of they constructed a model that predicts participants' results. They the residuals is what the model predicted versus what was actually observed. Those are the residuals, and QQ plots are essentially comparing mm, comparing the mm, comparing what was actually observed and what the model predicted and seeing how close they are together. And they assessed homoskedasticity. Homoskedasticity. Oh my goodness. Homoskedasticity. Who comes with these terms? Who comes with these terms? Who comes up with them? Okay, they assessed with scale location plots, which basically means they want to assess. Of course, they want to assess what's the difference between the predicted and the actual values, but they also want to see whether the variability in these actually is matched throughout the individual data points or the individual participants, that the variance is the same essentially. And due to the small sample size of 12 people, these assumptions could not be unequivocally confirmed, of course, but no large deviations were observed. So, as far as this pilot trial is concerned, there are no problems statistically. So, now it's time for the results. So, 7 men and 5 women were the participants with mean age 63.2 years, and the depression and anxiety scores were moderate, and they observed no serious adverse events. We should call basically side effects, fancy way of saying side effects. The majority of adverse events occurred during psilocybin sessions, so the acute effects of after taking the drug, which were anxiety, nausea, headache, as well as blood pressure and heart rate elevations. That were the most common, but none required medical intervention, which is quite good. That's quite well. Mm, and specifically, one of the participants reported increased thoughts about pursuing medically assisted dying when Parkinson's disease eventually leads to disability in the future. So here we can see the demographic and the clinical characteristics of participants at baseline. Basically, feel free to pause if you want to get a closer look. We can see the adverse events from the after at the different times at different points in time, and I got lost. Okay, so non-motor symptoms were significantly improved in the 1 week as well as in the 1 month follow-up, and we have fantastic, absolutely fantastic p-values, like lower than 0.001 many times, and motor symptoms were also significantly improved at both time points, and motor examination scores improved significantly as well, although it must be noted smaller effect sizes, and motor complication scores were minimal at baseline, though which is consistent with mild to moderate disease stages. And psychotic symptoms were minimal at baseline. Remember, the inclusion criteria was set so. The exclusion criteria was set so. is to reflect this, were significantly reduced post-treatment, even though they were minimal at baseline, which is very interesting. So performance was significantly improved post-treatment on the paired associates learning, which is a task that, as far as I remember, examines, tests, evaluates mm, visual recognition memory, but I might be lying and I don't want to lie here, so it's better to check again. Paired associate learning. Oops. Let's look at this. Can tab. Oh no. Okay, this tells me nothing. Let's see this Springer. Oh, so paired associate learning is an episodic memory paradigm in which pairs of items, for example, absence, hollow, are presented during one or more learning trials. At test, the first item is presented as a cue for a response to the second item. Memory for the test items by themselves is insufficient to support accurate paired associate learning memory performance. Instead, PAO assesses whether items have been associated or bound together in memory. So yeah, it's what what it says. It's quite literally what it says. Okay. uh, thank goodness I checked that. Mm, but I want to be as honest and truthful about. After all, we're all here to find out the truth. This is the main goal of science. Only that way we can help humanity. Okay, so the improvements in spatial working memory, and I sound like I'm marketing this study like I'm selling it, but it's really good. It's not. Um, I included it on purpose. I picked it on purpose, of course, because I think it's a recent big discovery. That's what we cover here in this week in neuroscience. And this again explains the follow-up points, but we got over that already. Okay, and probabilistic reversal learning, which I explained, and performance on match to sample, which that was the test that I was actually referring to. That's match to sample was the test that examines visual recognition, and this was significantly improved in 1 month follow-up only, and there were no significant changes for the other two cognitive tasks, which is reaction time and one-touch stockings of Cambridge, which, oh god, I forgot what this measures once again. I checked all of these before the stream and yet I keep forgetting, but oh, unusual traffic. What is it? I'm look, I know I am searching for drugs, but not that type of drugs, okay? Suspicious activity. Maybe this. ODS. Discontinued. Should ODS. This doesn't tell us anything either. Please. Oh my gosh. Why can't I find... Okay. I have another trick up my sleeve. Which is this one I read. Activity study. it's widely used as. Hmm. Oh, there we go, there we go, there we go. I saw an explanation. I saw it. I saw it. Where was it? There we go. One such stockings of Cambridge is a spatial planning test variant. Okay, so spatial planning. Finally, some explanation at least. Okay. I completely skipped over those, I'm sorry. Sorry. I need to work on my pronunciation. mm, where were we? Yes, so care partners reported significant improvements at both 1 week and 1 month follow-ups in the severity of neuropsychiatric symptoms, which again, such glorious, glorious, beautiful p-values, beautiful. Love it, love it. The first p-value, me in this study. Okay, so depression. I'm sorry, I'm talking about a very serious topic, and sometimes, but I try to at least maybe from time to time lighten up the mood. I try to. I think that's helpful to do from time to time. Okay, so depression was significantly improved in both 1 week and 1 month follow-up, and anxiety was improved in the 1 week follow-up, but changes were not significant at 1 month, which is a problem. But both depression and anxiety were significantly improved at the 3 month follow-up, which may be more important, I think, because of course long term, even if the effects require require longer to show up, at least it's better if they have long-term effects. I did not phrase that correctly at all, but I think you got what I said. So I highlighted nearly everything in the discussion just because it's such a good summary of the entire thing. And of course, to our knowledge, this is the first empirical report on the effects of psilocybin among people with Parkinson's disease. The intervention had a strong safety and tolerability profile in the sample. We did not observe concerning acute cardiovascular effects of psilocybin, worsening or emergence of psychotic symptoms, or negative effects on cognitive performance. We also did not find worsening of PD symptoms overall. On the contrary, participants experienced improvements in both non-motor and motor symptoms that persisted to the final assessment 1 month following drug administration. Improvements in mood dysfunction were rapid relative to standard pharmacotherapy, becoming apparent within 1 week of drug administration and sustained to the final assessment 3 months later. Care partners' ratings also indicated improvement in neuropsychiatric symptoms that persisted for at least 3 months. And lastly, treatment satisfaction was high, which is all around so good. Such good results. Most adverse effects, as we covered, occurred during psilocybin sessions and were comparable in frequency, severity, and duration to prior psilocybin trials. So it's basically similar to other clinical trials where they used psilocybin as treatment. Tolerability was also similar among patients not using dopaminergic treatment and those on carbidopa levodopa. And it must be noted that participants had mild to moderate PD severity and minimal psychotic symptoms at baseline, which means that basically additional research with people at varying disease stages is needed to fully characterize psilocybin's effects on Parkinson's disease psychosis. As we already mentioned, that is a worry when it comes to psilocybin treatment on people with Parkinson's disease. And two participants endorsed particularly challenging acute subjective experiences and experienced adverse events during the follow-up period. For one participant, this included thoughts about pursuing medically assisted dying in the future. As we covered, the experiences of these participants underscored the risks associated with high-dose psychedelic treatments, even when provided using a consistent medicinal product in a monitored setting and paired with skilled psychotherapeutic support. Mm, and also identifying predictors of treatment response, of course, will be essential for determining its real-world clinical utility. Which basically means, as I said, we don't have a clear understanding of all of the mechanisms involved. We need to understand the underlying mechanisms better, as is with a lot of things about the brain, of course. As we know, sadly, there's a lot of work to do when it comes to the brain, and I'm here for it. Honestly, it's my dream. Mm, so, cue the discussion notes. Uh, they observed significant and sustained improvements in depression and anxiety consistent with prior studies of psilocybin therapy for major depression and mood dysfunction associated with terminal cancer, which is very sad. At least I am happy that these kinds of people with these fates have at least something that can make it just a little bit better for them. Mm, and okay, so anecdotally, also some anecdotal evidence. Multiple participants described feeling better able to adapt to health-related challenges post-treatment, and this may be particularly important for people with PD who commonly experience demoralization that can interfere with the adaptive disease management that optimizes function. And cognitive flexibility improved post-treatment, and prior work suggests that enhanced cognitive flexibility may be a mechanism by which psilocybin therapy produces lasting benefits on well-being. And the large effect on non-motor symptoms likely reflects the fact that participants had a relatively high non-motor burden at baseline, whereas baseline depression and anxiety scores were near the mild or moderate cusp. That's a word I've never heard before. Uh, we'll learn something new every day, right? That's what this channel is all about. And the observed effects on depression and anxiety suggest that psilocybin therapy may have potential to address a critical gap in Parkinson's disease care. Something that I just thought about that I didn't show you was the graphs, the beautiful, beautiful graphs with lots of good p-values, except for this cross. Let me. The cross is the only p-value that was not statistically significant, as it was that I understood it here. So the cross means less than 0.1, which is quite far from 0.05, and is not statistically significant. So that's the only thing. And look at those scores. This is the one examining motor symptoms. In like all of the graphs indicate improvement. Number of reversals. This is the number of times people were able uh, mm, to reverse or to be cognitively flexible, and the more number of reversals, of course, the better cognitive flexibility. Uh, the pairs assisted learning Z score, which is also quite good, and SWM. I'm sorry. The SWM was spatial working memory. Yes. There's so kind of sometimes find it hard to keep up uh with these acronyms because they're everywhere. Those are the vitals if you're interested. And this is the depression score, which, as we can see, steady decline. And also we have a decline in the anxiety level, as we already discussed. So back to the discussion. The improvements in participants' motor symptoms, as well as their motor exams from pre to post treatment, were surprising. And one possible explanation for that, according to them, is that psilocybin could provide some degree of motor symptom relief, because the drug modulates dopamine regulated brain networks through its interactions with multiple serotonin receptor subtypes, as we covered earlier, and other treatments for mood dysfunction, as well as electroconvulsive therapy, which is therapy through electric shocks. And these have been shown to ameliorate motor symptoms in Parkinson's disease, likely via modulation of serotonergic and dopaminergic signaling, respectively. A second possibility, on the other hand, is that improved mood could lead to improved motor function, which is a very. This was the most interesting hypothesis to me. Depression itself is hypothesized to increase allostatic load. Allostatic load basically means the sort of wear and tear that happens to your body as a result of chronic stress. So depression itself increases allostatic load through hypothalamic pituitary axis activation, which leads to chronic activation, therefore chronic production of cortisol, the stress hormone as we know it, and inflammatory changes, inflammatory changes which mm, uh, which mm, lead to mm, inflammatory changes leading to dysfunctional uh, inflammation, which is basically uh, there are inflammatory pathways and mechanisms being activated unnecessarily, which leads to neurodegeneration, as we're going to see. Sorry about that. And mitochondrial dysfunction, as you all know, the mitochondria is the powerhouse of the cell. This old saying and meme nowadays, and downregulation of neurotropic factors, which are very important for neuroplasticity, for neurogeneration, neurogenesis. I'm pretty sure that was called, and all these things, as I said, ultimately resulting in neurodegeneration. Also, mood dysfunction often precedes the development of motor symptoms of Parkinson's disease by several years, and people with depression or anxiety earlier in life are twice as likely to develop Parkinson's disease. I wonder how many people's shot, or how many people's risk shot up by reading that. I wonder. Mm, so, a third potential explanation is that psilocybin impacts the pathophysiology of Parkinson's disease itself. The drug has been shown to modulate glutamatergic activity in prefrontal circuits, reduce inflammatory activity, induce gene expression relevant for neuroplasticity pathways, and promote neuronal growth. And as I said, the impaired glutamate homeostasis, which is a homeostasis, a balance of activity in the brain, dysregulated inflammation, as I said, leading to damage and reduced synaptic plasticity, are key elements of the neurodegenerative process in Parkinson's disease. And there is also this thing called the prodromal hypothesis, which posits that mood changes are a direct consequence of Parkinson's disease pathology that often manifest early in the course of illness. And if this is true, it is possible to imagine that the effects they observed on mood, on other non-motor symptoms, and on motor symptoms are the result of psilocybin modulating common mechanisms that drive these clinical features. And there are several important limitations of this study. Of course, we get to the limitations. First, of course, one of the first things we pointed out is the small sample size. That's, of course, characteristic to a pilot trial. And open label design means that all findings must be interpreted with caution, as always, I think. And positive expectancy is a well documented source of placebo response in psychedelic studies, and placebo effects are common in Parkinson's disease treatment. That's a good thing to know. And the sample was comprised of people with mild to moderate PD and excluded dementia, serious complications of cardiovascular disease, and multiple concomitant medications. So future trials can consider careful expansion of medical inclusion criteria. And also the ratio at ethnic diversity is poor, which exacerbates a major problem in psychedelic research. And the parameter space of psilocybin therapy is not yet well defined. They selected a therapeutic dose of 25 milligrams based on prior studies, though some participants experienced meaningful benefits following the 10 milligram administration, while 25 milligrams reliably produces an intense subjective experience. Whether that experience is critical for clinical improvement is unclear. It remains unclear. Furthermore, this study treated psilocybin therapy as a combined intervention, so psilocybin plus the psychotherapy sessions, and thus the relative contributions of drug versus psychotherapy cannot be determined. So, in conclusion, the results of this initial pilot study suggest that psilocybin therapy may have promise as a new treatment for motor dysfunction in Parkinson's disease, but rigorous efficacy testing is a crucial next step. Findings also raise the possibility that psilocybin could have cognitive and motoric benefits. So this study supports further investigation of psilocybin's effects in Parkinson's disease. So that was all from me, folks. I hope you enjoyed this episode of This Week in Neuroscience, and I hope to see you soon. Bye bye, everyone.